Hi, I'm Dr. Stu Hoffman, President and founder of ChiroSecure, and this is another follow-up show from our recent stroke strategy event. The goal of today's show is to do our best to bring the practicality of dealing with a potential stroke risk patient. This is not going to be an anatomy or physiology lesson. We're going to look at some key things you need to be aware of to help you lower the risk of doing what you do. The information we are presenting today is taken from my good friend Dr. Jerry Clum's presentation, Cervical Spine Adjusting and the Vertebral Artery, and the DVD of the same name. The DVD is available from the Association of Chiropractic Colleges at www.chirocolleges.com.
On behalf of the Association of Chiropractic Colleges, I'd like to express our thanks for you taking the initiative and making the time to review this lecture. In the final analysis, we hope that it will prove to be useful to you, more importantly to your patients, and also to the profession. Thank you very, very much. The concept of cervical spine adjusting in the vertebral artery and potential injuries to the artery is a very important and sometimes a very emotional subject for chiropractors. I think it's safe to say that at this point in time in our history, the issue of cervical spine adjusting and possible relationship to CVA is one of the most important public safety issues that we have on the table. There is nothing in our circumstance that rises to the level of concern that this situation does in, day out practice. It's a very rare circumstance. That doesn't mean because it is rare that we can pay less attention to it. It means the fact that if it's rare but serious, we need to continue to attend to it, and we need to continue to learn as much as we can about it. Hence, one of the main reasons why this lecture is being presented. The second consideration is that without a doubt, from a public relations perspective, this is one of the areas of greatest concern for our state associations, for our national associations, and for individual practitioners. The concept that we do something to the neck, this problem is somehow related to the neck, therefore what we do is related to this problem in a direct cause and effect relationship, is what the media seems to pick up. And that the great majority of these cases have nothing to do with the doctor of chiropractic. That being said, there are relationships with the chiropractor that we need to be aware of, we need to understand fully, and we need to address in our professional lives.
Two recent issues have brought stroke back into the public's attention. The first is the Katie May issue that has been all over social media. Katie May was a model having appeared in Playboy, Sports Illustrated, and other magazines and websites. She self-proclaimed herself Queen of Snapchat, but she also had nearly 2 million Instagram followers and was a major social media force. And you can see why this could be such a potential public relations nightmare. She died unexpectedly at the age of 34, leaving behind a 7-year-old daughter from complications of a stroke. As her family confirmed, and one of the circumstances that they are trying to determine was this caused by the chiropractor she had seen right before the time of her stroke? Well, remember, she also went to the chiropractor because she had fallen and hit her head earlier that day. Well, the second is a recent Reader's Digest article, which was put out on MSN. It was called The 9 Plain Truths About Alternative Medicine Doctors Desperately Want You to Know, which was related to chiropractic care and stroke, which advised that no one should have their neck adjusted by a chiropractor. Wow. Could you even imagine that? This had to be regurgitated from 2010 from MSN just to put out there again. So let's take a look at the incidence of stroke and the predisposing factors. We do not want to trivialize the fact that these events do happen, and that the number of doctors being accused or involved in a malpractice suit regarding stroke has been on the rise.
I'd like to put a little bit of focused attention on the incidence of stroke in the United States. From the literature, we can appreciate the fact that there are approximately 700,000 strokes of any kind that occur in the United States per year. Now, the first thing we need to recognize is that's probably a very soft number. The idea that that is a solid, firm, take it to the bank number, that there are 700,000 strokes period per year, just isn't reality. It's probably a very good guess, but it's not the reality of the day. That being said, we can begin to extrapolate what the likelihood on a population basis would be for a stroke to occur. If we begin with the assumption that we have a population in the United States of 300 million people, and we have an incidence rate of 700,000 strokes per year, then do the math and it comes out to approximately 233 strokes of any kind, any nature, any type per 100,000 population. Now, it's been reported in the literature that the incidence of vertebral artery dissection is 1 per 100,000 population. Well, if we use this data and extract it a little bit further, that would mean that there's approximately 3,000 cases of vertebral artery dissection occurring in the United States on an annual basis. The important point for us at this moment is to understand that the infinite majority of these cases occur in the course of patients' lives that don't involve a chiropractor in any shape, form, or fashion. The fact that there is a subset of these data that is related to or associated with chiropractic care in some way, whether it's temporal or causative, is an area that demands our attention and why we're even bothering with this lecture today. Getting down to the idea of what is the incidence data associated with this basic phenomenon involving chiropractic is a very hard number. From my perspective, and looking at the literature as well as the experience over 35 years at the college for 25 years at Life West and practice before that, the concept, I think, is we're reasonably safe to say that of those 3,000 cases that occur in the United States of vertebral artery dissection annually, a very, very few, perhaps a handful, are associated with chiropractic care either on a temporal or causative basis. This is an important perspective for us to understand. As chiropractors, we are acutely attuned to this circumstance. And when we hear a discussion of vertebral artery dissection, we automatically make a mental tie to was an adjustment part of the picture, etc. The reality is, in the vast, vast majority of cases, a chiropractor wasn't anywhere in sight, wasn't anywhere part of this patient's life and times. And that's a perspective that we need to keep in mind. That being said, if there was one patient for whom there was a relationship between our care and the occurrence of vertebral artery dissection, then that demands our attention. That's why we're here today.
Through the research that ChiroSecure has conducted with our partners, we have found that in the medical literature, there are over 72 simple everyday movements that are known as causes of vertebral artery dissection. Some of these include yoga, painting a ceiling, nosebleeds, hypertension, sexual activity, receiving anesthesia, receiving a shampoo, vomiting, sneezing, but also doing nothing. Some of these are just brought on without any known cause whatsoever.
Now, one of the most important things that you could take away from this discussion is a complete change in thinking regarding vertebral artery dissection in chiropractic care. Throughout the years, we have always heard that vertebral artery dissection, subsequent cerebrovascular accident, was associated with receiving a cervical spine adjustment. The current thinking is that to a greater or lesser extent, many of these patients walk into your office or my office in the process of dissection, with the dissection itself producing neck pain and headache, and as a result they consult the chiropractor. With respect to this concept that a significant percentage of persons who develop vertebral artery dissection in relationship to chiropractic care had the dissection when they presented for care, there's an emerging body of literature to support this concept.
There are no reliable tests to see if your patient is predisposed to have a vertebral artery dissection. As we move forward, there are things you can do to lower your risk. And as you go through these procedures, you still need to keep in mind that it's all about what the patient tells you and what your observations are. Keep good notes. Your documentation becomes everything. So whatever you observe, you need to make sure you document.
There are no good tests. There are no indicators. And aside from the heritable conditions we talked about, maybe a question on the case history, maybe a relationship to migraine, so on, there isn't really much to give you and I as practitioners a heads up one way or the other as to what's going on. Let's shift gears and talk about pre-adjustment screening tests. When I was in school 35 plus years ago, Phil George was a member of the faculty at the Palmer College of Chiropractic, and he is the gentleman who developed George's test. And we have all, over the years since that time, been confronted with various tests, whether it was Decline's test, or whether it was George's test, or whether it was Domain's, or whatever name was given to it. But basically a constellation of procedures to attempt to elicit the quality and the patency of the vertebral artery. And it was assumed in those early days after the development of these tests that they were in fact good and true indicators regarding the health and well-being of a vertebral artery. The fullness of time has indicated that that's not the case. The research since the development of these tests on the tests themselves has indicated that they provide a very, very high percentage of false positives and a very, very high percentage of false negatives. And the truth of the matter is the testing itself to determine the quality, the patency, and the adjustability, if you will, of the vertebral artery is not viable. The conventional wisdom has transitioned from you must do a screening test to you shouldn't do a screening test. Now, if I'm not suggesting that there isn't any use for positional testing, rotational testing, things of that nature. The provocative testing, where you attempt to introduce strain to elicit a change in the artery, is what is not being recommended at this time. If you look at a patient and then there is an obvious bruit and you can see a pulsation in the neck, I'm not suggesting that you don't pay attention to that. I'm not suggesting that if a patient turns their head to one side or the other and they become dizzy and they move toward passing out, that you not pay attention to that. What I am suggesting is that if you perform a George's test and the test is negative, that you are free to go about that patient without any worry. That simply isn't the case. And there is an emerging perspective that the performance of the test, and in particular the test with all of its components where the strains are introduced into the artery, for that person who is in progress may in fact trigger a more severe circumstance. So if we go back to the idea that what we do didn't cause the problem, but in fact the patient presented with the problem, then we have to look at, is the process of testing aggravating it, irritating it, worsening it, or complicating it? The conventional wisdom today is that the use of provocative testing procedures to introduce strains and stresses on the vertebral arteries, to use that as a measure of sufficiency of the artery to be able to deliver an adjustment, is not a viable consideration. And the conventional wisdom today is that the practitioner should not perform those provocative tests. Now,
we're going to look at what you, as the practitioner, needs to know to help ascertain whether this is a high-risk patient or not.
And the other approaches, very simply, are the things that we do very well with. And that's listening to and reacting to our gut. The evaluative tools at this point in the discussion, without being a wise guy, are very simply your ears, your eyes, and your gut. Think about and feel what's going on with that patient. So what are you supposed to do in your office on Monday morning? If there are no clear-cut predisposing factors suggesting a VAD, if there are no testing procedures helpful in ruling out potential VAD practices, and if the great majority of VAD in progress patients present with musculoskeletal symptoms mimicking what we routinely see in practice, then what are you to do on Monday morning? It comes down to appreciating your diagnostic ability, appreciating your evaluative ability, and appreciating the subtle changes you see in patients. The reality is it's time for us to look, to listen, to ask, and to think relative to what's going on in that patient. What are you going to be looking for? Every chiropractor in the world owes a debt of thanks to Alan Terrett. Alan Terrett is the gentleman who went back through the literature and did an analysis of virtually everything that had been published, suggesting a relationship between cervical spine adjusting and stroke. And you know, as I do, that the literature often makes reference to it being related to chiropractic care or a chiropractor. And Dr. Terrett was the one that found that so many of these cases, a chiropractor wasn't involved, a person trained as a chiropractor wasn't involved, and that because it looked like what we do, it was called what we do. And because the person looked like we do when we do it, they were assumed to be a chiropractor or were referred to as a chiropractor. Alan Terrett gave us that information and dissected out that information, tremendous value to the entire profession worldwide. What Alan also put on the table was what he described as the 5 Ds, the A, and the 3 Ns. In terms of what to look for in your office, the first of the Ds is dizziness. When a patient comes in experiencing dizziness, it should be a concern to all of us. That being said, dizziness is a very common symptom among patients who present for chiropractic care. Dizziness is also a common sequelae that we see when a patient gets up off of an adjusting table. A person's been laying on a table for a period of time, minutes and so on, and then gets up quickly. It's not unusual for them to experience a degree of dizziness. That's not what I'm talking about. I'm talking about a person who has a profound level of dizziness, not just a little bit of lightheadedness, not just a positional change, but a significant level of dizziness. A person for whom this is very unusual. If this is a person with a migraine history, dizziness is a part of the migraine pattern that they've had. That's not what I'm talking about. I'm talking about dizziness apart from any explainable circumstance. Obviously, if the individual has labyrinthitis, something of that nature, dizziness would be expected in that environment and not anything to be associated with a VAD. But the reality is that we need to look at the presence of dizziness in our patients. The second thing, which would be a very obvious one, is we need to look for the presence of drop attacks. If we're talking about an individual that in one moment is standing, talking, articulating, and dealing with another individual and bam, hits the deck moments later with varying degrees of consciousness, obviously that would be a concern to all of us. The third D from Alan is diplopia. When we have a patient that presents with double vision, it should be an alarm to all of us. Now again, we're not talking about a little bit of blurriness in the vision after getting an adjustment. For me personally, if I lay face down on an activator table or a high-low table for a couple minutes, when I get up I have trouble focusing my vision. Even if you never touch me, I have a little bit of a problem focusing my vision for a few minutes afterwards. Put my glasses on, 4 or 5 minutes later, I'm fine. That's not what I'm talking about. I'm talking about frank double vision. When that presents on the front end or presents subsequent to an adjustment, we need to be very attentive to that. The fourth consideration, the fourth D from Alan, is dysarthria. Excuse me, no pun intended. If the patient has an inability to speak or is speaking in an abnormal pattern, speaking with an abnormal cadence, their speech has been altered from what you know to be the norm as a result of something before they presented for care or after care, something you should be concerned about. And then the fifth D, dysphagia. If the individual has difficulty swallowing, indicating a potential cranial nerve involvement, something of that nature, then obviously you want to be responsive to that. The A that Alan made reference to is ataxia. You want to watch the gait of that patient. Is their gait normal? Are they kneading the wall? How are they moving about in the office after their care? Do you see anything unusual about it? And then we move on to the 3 Ns. The 3 Ns are nausea, nystagmus, and numbness. If the patient experiences nausea after an adjustment, it should be something that concerns all of us. If the patient experiences numbness, particularly facial numbness, after an adjustment, it should be something that concerns the practitioner. And then if the patient develops an nystagmus type response after an adjustment, again, should be something that concerns the practitioner. Now the issue isn't one of these symptoms, but more the development of a constellation of symptoms. Now having said that, let me go back to drop attacks, for example. If we're talking about drop attacks, we don't need many other symptoms to decide that we might want to get this patient out for a referral. But if we're talking about dizziness, if we're talking about a little bit of blurred vision, if we're talking about a little bit of a change in the gait, maybe we're not talking about anything other than positional changes, and given 15, 20 seconds, a minute or two, everything's normal. But when we're talking about persistency, and we're talking about the development of a constellation of symptoms, everyone's red flags ought to go up geometrically at that point. It's the development of a pattern, it's the development of a cluster of symptoms that all have neurologic origins, that all have cranial nerve relationships, that begin to cause us to be concerned. This is before an adjustment or after an adjustment, the concern should be there. I said before that up to 50% of patients with VAD present with a primary complaint of neck pain and headache. It's important when patients present with out of the blue neck pain and headache. They weren't playing sports over the weekend, they weren't in a car accident, they weren't doing this, they weren't doing that, they just out of the blue woke up with it. That should be important to us. I'll come back and talk about the automobile accident case in just a little bit, but that individual that just came out of the blue should be an important consideration for us relative to that neck pain and that headache. And then we look at the 5 Ds, the ataxia, and the 3 Ns to see where we are. And it's that constellation of symptoms and the development of the symptoms, as well as the degree and the severity of them, that should cause our respective alarms to go off in our brain.
Also, we all need to bring the staff in here, and they should always be involved. If it's me, I'd want to have my staff watching this presentation right along with you. If they aren't, you certainly could have a staff meeting and educate your staff about these types of situations. Specifically, if the patient complains to your staff after you've already adjusted them and you're already back with another patient, they know that something may not be right and that it is important to have an office policy as to exactly what steps should take place next.
Let's look at what you and your staff should be looking for when you have any concern or any potential concern about a VAD response to care. Frankly, these are things that your staff, as well as you, should be looking at regardless of whether you've got any concern. They're just good indicators and good markers to keep in mind. One of the important reasons to involve your staff is that while a patient may be with you, receive an adjustment, you have a good conversation after the adjustment, everything's fine, you move on to the next patient, the patient moves to the front desk. In that time that they move away from you, they may develop symptoms that you should know about and be aware of, but they simply didn't develop them while they were with you, but given that few minutes to get out to the front desk, they did develop them. So your staff, as well as you, should be attuned to listening for any changes in speech patterns, whether the speech is slurred, whether there's a change in the intonation in the voice, whether there is some modification to how the patient is articulating. Anything of that nature should cause bells to go off for you and for your staff. You want to listen for the context in speech. You want to look for the presence of any giddiness or inappropriate, what we might call pseudobulbar behavior, where the person is just not responding to the situation normally. They're laughing at areas that aren't funny, they're terribly sad about areas that are, and we've got this whole out of sorts consideration going on. But there's one important, almost pathognomonic statement from a patient, and we need to keep this in mind whether it's the first adjustment or the 100th adjustment, whether you've seen this patient once a week for their life or you've seen them once every 10 years. When you hear this statement from the patient, every one of us should stop dead in our tracks. The phrase, as I refer to it, is very simple. When the patient says, I have a pain in my head and neck, or a pain in my head or neck, unlike anything I've ever had before in my life, stop. What the patient is telling you and I when they say that pain in the head or neck, unlike anything I've ever had before in my life, is I've got a good chance that this is a VAD going on. What we're looking for here, head pain isn't unusual in a chiropractor's office, neck pain isn't unusual, but to join those together with that phrase, unlike anything I ever had before in my life. When you hear that, stop. Just stop. You need to back up and start to question the patient more thoroughly. You need to go into as much detail as necessary to get you to a point of comfort regarding what's going on with that patient. You obviously want to look much more closely at the neurologicals at that point. You want to look at the history issues associated with that patient. Begin to try and pull together the pieces of their experiences in the days, weeks before seeing you that day that would begin to create the pattern that would indicate to you that something of a VAD nature is underway. According to the literature, for those patients who experienced a VAD, on follow-up, 50% had a recent appearance of a new chief complaint of upper quadrant neck pain and or pain in the hemicranium. The pain was described as throbbing, steady, sharp, or the classic description, the thunderclap headache. The thunderclap headache is as much of a sign of a VAD in progress as you and I are ever going to get in practice. This is the headache that if you've ever been on a country road in Alabama or Georgia during a thunderstorm and you're riding along and that lightning strikes right on the road next to you or a telephone pole or right by your car, you know that clap of thunder is just rattles you to your core of your being. This thunderclap headache is the kind of headache that is just, it stops that person cold. It's this intense, resounding headache. Can be very brief, but it's extremely sharp. And it's the presence of that headache when there's no other explanation for it that should cause you and I to be concerned about what's going on in that individual. If you notice the slide that's appearing right now, you'll see that there's a specific pain pattern associated with referral pain coming from injury to the vertebral artery, and there's also a pain pattern associated with pain coming from an injury to the internal carotid artery. You'll notice that the internal carotid artery pain is more of an anterior facial pain and an anterior neck pain versus the vertebral artery pain, which is more of a posterior neck pain, an occipital pain, and higher up in the head and skull than it is with the internal carotid characterization. At this point, you want to ask the patient, you want to stop and back up a little bit. Tell me some more about this pain. Were you doing anything before you experienced the pain? Did it come out of the blue? How do you feel otherwise? Are you lightheaded? Are you dizzy? How's your appetite? So on. Stopping cold in your tracks when you hear that phrase, a pain unlike anything I've ever had before in my life, will cause your circumstances down the road and the patient's circumstances down the road in certain cases to be infinitely better than if you don't. Taking a step back, slowing down, paying close attention to everything about that patient is the order of the day. Moving cautiously, being discreet is the approach that we need at that point for your interest and for the patient's interest. In the presence of a patient who expresses non-traumatic or post-whiplash neck pain as a new chief complaint, who refers to the pain as unlike anything they ever had before, who's exhibiting other neurological symptoms, referral for evaluation for possible VAD before adjusting is strongly recommended. You need to have someone in your sphere of influence and contacts that you can pick up the phone and say, Charlie, this is Jerry. I need you to humor me on this one. I think this is what's going on. And have them cooperate with you to make sure that patient gets a proper evaluation. If you have a neurologist that you can talk to, someone that will cooperate with you to get the testing done to make sure this patient is properly evaluated, you may save the patient a great degree of discomfort and a great degree of problem, and yourself as well the same.
For those of you that use software to do all of your practice management and documentation, please understand this. If you have a patient that indicates something to you, pain in a certain area or anything that is not in the usual script of that software, make sure you add a note to the notes for that day. You don't want to leave something out just because it wasn't pre-scripted into the software that you happen to be utilizing. Statistically speaking, this is not going to happen to you. But that's what I hear from all the doctors that I speak with around the country. Unfortunately, it does happen to some. And what I've experienced is when it happens, it didn't matter if you use a diversified adjusting procedure, or if you're an upper cervical doctor or an activator doctor or any other type of technique that may be utilized. It still happens. And the most important thing from my perspective at this point, after the adjustment, if you're finding that that patient is responding in a very negative fashion, especially with these types of symptoms where they're getting dizzy, that is not normal. If they're vomiting, that is not normal. It is imperative that you recognize these types of situations and act upon them immediately.
Now, when a patient shows signs of a possible VAD following an adjustment, how do you handle it? Where do you go from there? The truth of the matter is that your management of the situation and your documentation of the situation are the most important things that will determine the outcome of that circumstance. This management opportunity is one that is absolutely hands-on. You cannot be casual about this. You cannot be laissez-faire about this. You have got to be extremely attentive to what's going on with that patient. And if you do so, you will reduce the mortality, you will reduce the morbidity, and you'll reduce the liability that you or anyone else downstream will follow, that may follow. Your recognition of the post-adjustment symptomatic picture is critical. One of the things that we tend to do is assume that because it's extremely rare, it won't happen to me or it didn't happen to me. It didn't happen in my office. It's a 1 in a million. Who am I to think a 1 in a million thing is going to happen in my world? Well, I live in California, and twice a week I go down and I put down my $1 and I buy a lottery ticket. And the chances of me winning that lottery are about 1 in 40 million. And I think every week with my $1, I'm going to win the lottery. The reality here is it can happen in your office. It can happen with your patient. It doesn't matter how good your technique is. It doesn't matter how skilled you are as a clinician. It doesn't matter how long you've been in practice. Nothing matters other than the fact that it can occur. It could have walked in the door and it was undetectable. It could have happened on your adjusting table. I don't know. I don't know how to divine that out and seek that out, one versus the other. But the entertaining of the possibility that it can happen and that it did happen in the office is one that you have to entertain for your sake as well as for the patient's. If the patient at that point shows any of the 5 Ds, the ataxia, or the 3 Ns, the dizziness, the drop attacks, the diplopia, the dysarthria, dysphagia, ataxia, nausea, nystagmus, or numbness, your antenna should go up. These are not the signs you want to see developing secondary to an adjustment. As you see them, they should get more and more of your attention as they develop. If the symptoms are very mild and appear to be transient, it's your responsibility to monitor them and monitor them for their continued decrease and on to the resolution. If those symptoms are severe or become severe, it's your responsibility to seek emergency services immediately. Each and every situation will require a different response on your part. But in general, we should be monitoring the patient's vital signs at this point, as well as the specific neurological signs that drew our attention. The important issue here is, to go back to Tom Cruise and the movie Top Gun, you never leave your wingman. I don't care who's in the waiting room. I don't care if the governor's in the waiting room. I don't care if the president of the state association is in the waiting room, the chairman of the board of examiners. Doesn't make any difference. You never leave the patient at that point. Imagine you're in deposition down the road. You've had an adverse circumstance that occurred secondary to an adjustment, and in questioning, it comes up, what did you do? Well, I monitored the patient, I went on, adjusted a few more patients, and came back and looked at them again. The minute you step away from that person in distress, you're in trouble. Even if your stepping away caused no complication or harm to that individual, the fact that someone who was not in distress was put in a greater priority position than someone who was in distress creates a problem for you and for your liability carrier as well. Your attention needs to be this patient and no one or nothing else at that point. In this environment, the availability of baseline vitals can be very helpful for you to appreciate what's normal or abnormal. If a person's heart rate is changing in response to this, not knowing what normal is will leave you at a significant disadvantage. Now, if the symptoms are very transient and they are very limited and they resolve quickly, taking a position of watchful waiting is prudent. We cannot be in a position or cannot be expected to be in a position that everybody that gets dizzy after an adjustment winds up going to an emergency room getting an MRA. It's not simply possible, and it's not good health care. There will be more complications from the MRA testing than there would be from the dizziness to begin with at that point. But it is incumbent upon you and I to consider the area adjusted, to consider the type of adjustment given, and to consider if an alternative approach to the care would be in order. Because we practice a given technique approach doesn't mean that we can fail to move away from that if it's in the best interest to the patient to move away from that. And most importantly, when you've got that patient that had a little bit of a blip following or associated with an adjustment, things have resolved and calmed down, my advice and counsel to you is do not adjust that patient again at that time.
I always tend to hear stories from chiropractors that they had a patient in the office, they adjusted them, and then the patient does that spin deal where they want to see if their head can now go 360 degrees, even though they couldn't move it 2 inches one way prior to that adjustment. And when this happens, the doctor will respond to the patient because the patient may say, well, doc, that was much, much better, but I still feel a little bit stuck down here. Can you help? And all too often, the doctor readjusts that patient. My experience is that's when the doctor gets into trouble because they did more than they should have on that one visit. Practice Management 101. If you think that they need another adjustment, let what you did settle down and then have them come back the next day, reevaluate, and see if there's something either that you missed or something else that has now shown up. And you'll be so much better off for not doing it on that same visit. And especially if that patient had a negative response to your adjustment, you certainly do not want to go back in and readjust on that visit.
When a patient begins to show neurological signs, when a patient begins to move in the direction of being neurologically compromised, stop your cervical spine adjusting, and I would say at that point the other adjusting becomes relatively less important as well until that patient stabilizes and normalizes. I would not adjust that patient that day again. If the symptoms do not resolve, you want to monitor the patient, stay with the patient, and again, no matter how stacked up your waiting room is, no matter who's out there, you want to monitor this patient, stay with the patient. You want to watch for the development of additional symptoms. You want to note any change in the mental status. You want to note any degree of confusion, if any, that arises. And generally, you want to be extremely attentive to what's going on with this patient. And I'll restate my advice to you again. Do not adjust that patient at that time. Let me take a sidestep here and affirm something to you. I am a pro-adjustment chiropractor. When I was a 12-year-old kid, adjustments changed my life. I got my eyesight back as a result of chiropractic care. I have a daughter who was 28 years old this summer. And 28 years ago this summer, a chiropractor was smuggled into the neonatal nursery at Northside Hospital in Atlanta, Georgia, the fellow that gave me my first adjustment, and adjusted her, and she is alive today because of that adjustment. I am not an anti-adjustment guy. Quite the contrary. I am a pro-adjustment guy. But I am also aware of the fact that there are times when discretion is the better part of valor. At this point, where this patient may have developed a dissection, I don't know of any type of adjustment, any type of thrust that will cause the swelling in the wall of that artery or the tear in the flap of that artery to reduce or heal spontaneously. That is a matter that is going to take time. That doesn't mean never adjust the patient again. It means at that time, be discreet, be reserved, and be cautious. If the symptoms persist or if the symptoms worsen, seek emergency support services. I'm not talking about over hours here, I'm talking about over minutes. Monitor the patient while you've called support services, put the patient in a recovery position, and be prepared to answer the questions for the group that shows up to take care of that patient. And let me say it one more time, do not adjust that patient again at that time. Why do I say that? I've said this twice before, let me say it one more time. If the patient is experiencing a dissection, I don't know of any form of adjustment that will minimize the consequences of that dissection, and I do appreciate the fact that the introduction of another force into that area of injury may cause greater swelling or greater emboli generation than if we had left the area alone.
When your patient seems unstable or in a fragile state after an adjustment because you think that they had a negative response, like we've been talking about, never ever let them leave on their own. First of all, you should only let them leave if they have someone to be with them and someone driving them. Second, if you're going to be the doctor, call 911. Sometimes doctors have told me, patients don't want me to call 911, so I tried not to do that. Well, when it's an emergency situation, and sometimes these become emergencies, you don't use the patient's judgment at that point in time. You make sure you do not only what you're responsible to do, but what's right. And what's right is getting someone medical first aid as soon as physically possible, because that will absolutely affect an outcome. And the worst case scenario is you call 911 and there's nothing wrong. So what? At least you did what was right and being proactive for your patient.
So how do you limit your professional liability outcome in this environment? What can you and I do in this environment to minimize the complications for the patient, for ourselves, and for the liability picture? Well, the first and most important thing is that we have to recognize what's going on. Our failure to recognize the developing constellation of symptoms in retrospect will be held against us, and quite possibly as it should be. To write off what's going on as a normal reaction to an adjustment or a typical reaction to an adjustment is a mistake on our part. At this point, when we're talking about neurological sequelae secondary to an adjustment, normal and typical aren't part of the discussion. Our failure to monitor the patient, our failure to document what's going on, our failure to stay with the patient, and our failure to develop a thought process about what's going on will accrue to our detriment and to the patient's detriment over time. Our failure to manage this thing properly and to be responsive to the best interests of the patient, because we don't want an ambulance coming to the office or we don't want a gurney coming through the waiting room when it's crowded, whatever consideration may be offered, it is absolutely no defense. The best interest of the patient has to be served at this moment. Readjusting the patient at that time. This is the single most common complicating factor that takes an unfortunate situation to a bad situation or a bad situation to a disastrous situation. we will stop what we're doing at that point, not introduce another thrust until this situation is evaluated and calms down, we will see a significant percentage of this problem go away. If you appreciate the fact that up to 50% of this problem can be identified on the front end through recognition of the phrase, a pain unlike anything I've ever had before in my life, and another significant percentage of this problem can be minimized by not delivering that second adjustment or that third adjustment, we now have a situation that is way more manageable. And maybe we're talking 66 to 75% of this problem is behind us and is never realized because we understood those two factors. If the patient is in a compromised neurological state or moving in that direction, and you take a perspective that you're going to send them home to rest and send them home to relax and so on, very unwise decision. If they're neurologically compromised, they belong in an emergency room, period. They don't belong in their living room. They don't belong under the care of their spouse. They belong in an emergency room. If you take a casual approach to this situation, you know, Mrs. Smith, you might want to see a neurologist. You might want to stop by the emergency room. This is not a might want to environment or might want to moment. This is, we're going to see that you get to the emergency room moment. Failing to document what you did, what you were thinking, being less than honest and explicit in the record. I've been involved as an expert witness in a number of professional liability cases in defense of chiropractors. Once a chiropractor fails to be honest in the record or misleads anything to do with the record, all bets are off. That cannot be rehabilitated. When you're involved in this situation, be honest, be truthful, be forthright. If you're less than honest, if you disclose less than all you should, then down the road, if that information comes forward, you cannot recover from that.
You should always have an action plan in your office. As I've discussed earlier, if your staff isn't watching this with you, you certainly should have meetings about what happens in your office if an emergency takes place. Do you have an action plan? Does your front desk have emergency numbers at their disposal? Do you go through possible scenarios that could happen with patients coming into your office or even outside of your office? Do you have a code, an office code, to stop what you are doing when an emergency takes place? Do you have a plan that's in writing that all of your staff get to know, see, and be exposed to?
Have a plan for what you would do. Perhaps one of the more important takeaway messages I can leave with you as a result of this lecture is, do you and your staff understand what should be done, what order it should be done in the presence of a problem of this nature in your office? Do you have an oxygen supply on hand? Do you have emergency numbers on hand? Do you have the ambulance service number on hand? Do you have the ER person? Do you know somebody down there? Is all that information there? Is there a code in your office that everybody in the office knows, stop what you're doing, pay attention to this situation, this is the order of the day? The development of a written plan for your office, even if there's only 2 of you in that office, is important to you being prepared, you exhibiting your preparation for this, your appreciation for this, and your readiness to respond to it if it should ever present itself. You cannot over-document this situation. You cannot. Obviously, in the heat of the moment, you can't be expected to be taking notes about what's going on, but as soon as you have the time, making the record complete and whole to the best of your ability will serve you and the patient well over time. Thank you on behalf of your patients. Thank you on behalf of your colleagues. Thank you on behalf of the profession. Thank you for taking the time to learn a little bit more, to reinforce your understanding and awareness of the circumstances of cervical spine adjusting and its possible relationship to vertebral artery dissection.
Thank you for being with us today. I hope that some of this information will be useful and you're able to implement immediately for your own practice. If you miss any part of it, or you want to review, or you want to sit and utilize this with your staff, you can revisit it on the ChiroSecure website, and or certainly download the ChiroSecure app from either Google or Apple. And we appreciate you being with us. So again, the information we presented today has been taken from my good friend, Dr. Jerry Clum's presentation, Cervical Spine Adjusting and the Vertebral Artery, and the DVD of the same name. The DVD is available from the Association of Chiropractic Colleges at www.chirocolleges.com. Thanks for being with us.